And it's a great pleasure to talk about my favorite topic. We have 30 minutes to resolve all remaining challenges in chronic graft-versus-host disease. So thank you, GvHD Hub, for this opportunity. We have selected 9 questions from one of my prior presentations to address in this esteemed forum in the rapid fire format. And the rationale for this is, and I have more questions, but there are like 9 here. Rationale is, of course, there is a overwhelming awareness about the progress we have achieved in chronic graft-versus-host disease over the last 20 years. We have pathways for regulatory approvals. We know how to understand better the pathophysiology. We know we have 4 new FDA approvals over recent years since 2017 for the steroid-refractory disease, and clearly the increasing awareness of chronic GvHD resulted in attempts to prevent. So we can confidently say that the current standard is probably chronic GvHD incidence. It's about half as much as we used to see 10 or 15 years ago. Of course, there are many challenges remaining. We are still stuck in the prednisone as a frontline therapy. We don't have really strong guidance how to use the sequence of subsequent treatments, which drug comes after one other or first. Responses to our new agents are still mostly partial, about 5 to 10% complete responses, so it's suboptimal. There are no standard or personalized approaches to prevention or preemption. We are still facing highly morbid forms like lung GvHD, severe sclerosis, or atypical manifestations. And actually, just came out recently in a Viewpoint article in Blood by Pidala and colleagues indicating actually that the prevalence of chronic GvHD seems to be continuously rising, even based on conservative estimates. It's mainly consequence of number of things. It still happens, and patients live longer, and the treatments are better. So I'll stop here as a background, and we have 9 questions here. And so I'll read them, and then we have a brief time. I would like everybody to provide quick input as a pretext for any kind of future more in-depth conversations. So one of the remaining questions is how to choose the right drug for the right patient. So it's clearly we don't know the answer, right? Specifically in terms of refractory disease, it's still mostly trial and error, and we choose drugs mainly based on the feasibility, expected toxicity, but and certainly it's piles up costs and cumulative toxicities, this trial error approach. So anybody wants to take on this, how to choose the right drug for the right patient? And kind of in refractory disease, probably primarily, frontline is even harder.
No, thank you, Steve. Really, I think this topic is very important. And actually, I like the title, answering the unanswered questions. So we managed to do this. It means we are heroes. But nevertheless, I think it's very important. Something I maybe would like to raise within our group is choosing the right drug. And maybe because we are in an expert group, I wonder whether we have situations where actually we can avoid going to steroids, because this is more and more something of concern. Of course, you have highlighted the fact that for a first-line treatment, we're still stuck with prednisone. But obviously, and I don't know the opinion of the team, one would like to see in some patient maybe moving away from prednisone, or at least establishing a new concept of maybe, I don't know, 1 month, 2 months of treatment with prednisone, and then because of the new available drugs, and you have nicely reminded us that we have the ibrutinib approved in the US, we have ruxolitinib approved both in the US and rest of the world. We have more recently belumosudil, and very, very recently there was axatilimab. So I don't know, any thoughts on this?
Okay, we have Dr. Bazarbachi first, raising hand.
Good evening, everybody, and thank you for this important topic. So before discussing drug, can we define situations of chronic GvHD, if any, where we would start with ECP without using any drug?
I mean, sorry to interrupt. What I could mention is that I just saw a patient this morning. If you have sclerodermatous chronic GvHD of the skin, superficial or deep sclerosis, and patients are under, this patient is under a combination of ECP and ruxolitinib. He's improving very well. His ulcerations are meantime closed without any steroids.
The question was without any drug, right?
Well, we also have patients who just have ECP and no ruxo and no steroids.
Okay.
But this is just for scleroderma. I would not do otherwise for any other manifestation.
So Hildegard, you mean you have patients who never received prednisone, for instance, and or other drugs, and are being treated just by ECP?
No, for these who have scleroderma, they had other chronic manifestations before, because usually chronic GvHD does not start out with deep sclerosis.
Yeah.
Okay. Florent, yeah.
Yeah, sorry, I missed the beginning of the meeting, but if I can jump in regarding Mohamad, question. I think this is more regarding the first line treatments. If we get rid of steroids, so we have some randomized ongoing study that may bring some answer if we show that we're able to decrease very quickly the steroids in the control arm. I think it will not be on. It's go to the right drug for the right patient, because in the randomized study, maybe there will be some patient that will benefit from the belumosudil, but not all of them. So I think it will be very important to have also some subgroup analysis to look in details which subgroups of chronic GvHD will benefit for the treatment. And we know that in some patients we'll be able to decrease the steroids very quickly, but in some patients that have some very inflammatory feature of chronic GvHD, it will be important at least to have the steroid for the beginning. Will not be, I think, be able to get rid of the steroids for all patients.
Anybody else wants to take on this? Certainly, we don't aspire to answer all these questions, but I think it's a good discussion to keep going in the future. So, anybody else wants to answer this? Okay, so it's still challenge, second line, front line, and there are also front line being pursued, and their challenges, I can tell you right now, and different considerations, but probably need to move to the next question. So how to elicit high rates of complete responses? That applies to front line, even more to second line, and anybody wants to take on this?
Well, again, I would like to be the devil advocate regarding response assessment when it comes to chronic GvHD, because obviously, although we do have the NIH criteria, actually it's very tricky because sometimes you have responses in some organs, not others. The magnitude of response may not be the same in different organs. Some organs may be more resistant than others. And the last but not least, I think one of the most challenging part is, especially in the refractory setting, assessing the response when you have some damage which is already established there. So I don't know how can we handle all of these complexities.
And May I just add here, I think, Stephen, we have discussed that before also within the NH consensus. But when you look at the recent publications like this axatilimab or now ruxo in scleroderma, there the skin responses are especially low. And it may, although then everyone claims who were treating patients and used the drugs, that that patients are improving. For ruxo in scleroderma, actually the response rates in joints, fascia are very high, and skin is only 19%, what really makes you wonder. So I'm not sure whether it would not also be time to critically think about ways how we could better demonstrate improvement in the skin, especially.
Dr. Arat?
Yeah, so the eliciting the high rate. So if we have, especially from the patients we want, so not only the complete response assessment by ourselves, the patient-reported outcomes is very important, I guess. It's very much highlighted in many papers of you as well. And so sometimes we say, okay, we have a complete response, but the patients is telling us so that the problems are not completely resolved. If the sclerotic phase is very high, so our actually expectations and the patient's expectations very high because they are nearly crippled. And so after treatment, they go to the daily life and so they feel better. But for example, if you look from the bronchiolitis obliterans phase on, so there is no really a complete response. And so so this is an ongoing phase. What I'm telling is the higher is the grade, so and the better is the response. So we see that the patient and the higher is to elicit. But if there's a very mild one, so it's not so easy to evaluate, and the skin and joint issue is getting worse and worse, as Hildegard underlined. And this is the major problem, I think, in our patients: the sclerotic skins, the joint involvement. The others are with the exception of the bronchiolitis obliterans. But do we have any agent? Actually, we are stuck with our national regulations, and so if we want to try to use the combinations, etc., we are not, there are not so much clinical studies. So maybe we have vehicles, but we can use them at once.
So for
Dr.
the
Nagler.
question how to elect high rate of complete responses, I think that we, I mean, like most of the field of medicine, we are talking about combination therapy. And now that we have several drugs that tackle various angles in the pathophysiology of chronic GvHD, we have a way to do it. The issue is, of course, the toxicity. So, I mean, if we can reduce the doses of some of these drugs, and they will be still effective, or give alternate days, of the several drugs, we may succeed to treat with a combination and maybe increase the rate of complete responses.
Well, thank you also. Obviously, it's revolving around better assessments of benefit. And the other thing is how to use drugs effectively. Okay, I'll move next question. It's how to choose timing when tapering immunosuppressive agents. It's an ongoing headache, right? This question has been around for a very long time, and we still are in the guessing stage. So anybody wants to take on this?
But maybe, Stephen, I can just add to that. When we did our recent survey within Germany, Austria, and Switzerland, as it turns out, there is policies at centers who are using only 2 or 3 drugs, and there's others who just add and add and add, like having steroids, calcineurin inhibitor, ruxo, belumosudil. So I think this would also be a topic, although it's difficult with the data we have available, because the more you add, the less likely or the more difficult it is to then assess who actually was more efficient and where does the response come from. And then, of course, also tapering is an issue because we'd like to have the most efficient one the longest if it's not steroids.
Thank you, Hildegard. Anybody else?
I think Hildegard is raising an important problem because there is this paradoxical picture in our field where actually we don't like immunosuppressive therapy, and we know it generates lots of side effects and complications over the long term. However, we know also that we keep on accumulating, I would say, the immunosuppressive agents, and we are quite conservative in trying to get rid of some agents where we believe they were they didn't work. On the other hand, our masters used to say, oh, be careful, don't decrease it quickly to avoid any flare and so on. So maybe time has come today, and that brings me maybe slightly to the earlier question and to Arnon's remark, that actually we need to hit hard and try to win from the first line. And this is why combining one of these novel agents, whether belumosudil, axatilimab, ruxolitinib, with prednisone can be of added benefit or value. I know it has been also combined with ECP frontline, although ECP is not exactly a drug, so the assessment is a little bit more complex. I don't know, any thoughts on how to bring these effective new drugs earlier in the course of the disease?
Anybody has comments? This goes to question of frontline treatments with or with minimal steroids, and we clearly need this kind of clinical trials. I can tell you from a very early preliminary experience with one pilot study, it's well, there are two things. One, in practice, surveys show that 20% of physicians already start without steroids, both in European and US surveys. So it's very interesting without the evidence. Now, in practice, there are some challenges. One, it's my impression, the responses, what we see with same drugs in frontline, it's maybe actually quite different than we expected, or even I would argue could be less, because it's a different population, more heterogeneous, and without steroids, we're probably gonna need at least 2 drugs to combine. We need clinical trials, and the other thing is the challenges with enrollment. We all claim that, well, we hate steroids, we need, no steroid regimens. Well, when you have a trial, then people don't send patients because everybody knows the prednisone is the best, So I'm just saying there are some challenges, but, I think the idea is fantastic. I mean, clearly, it's an amazing discussion, and in terms of tapering, 2 things. One, going to biomarkers that we don't have, and 2, not all drugs need to be necessarily that immunosuppressive. So, if we have drugs that can be tolerated years and years without serious side effects, controlling that may be okay too. So, it's just different ways of, Thank you for comments. How do we treat bronchiolitis obliterans syndrome? We heard before from Dr. Arat, how tough nut to crack is this. So anybody wants to crack it?
I mean, I guess that's what we also discussed and what is also written in Daniel's paper on these highly morbid manifestations of chronic GvHD. To me, especially for BOS, it's extremely important to diagnose it early. Even better would be if it have a biomarker that is indicating that this is in an individual at high risk of developing BOS. But since we do not have this available, my main first goal would be to diagnose it early by doing serial pulmonary function tests, do a proper workup when the FEV1 is decreasing, and then have a very efficient first-line therapy, especially for BOS, I guess, since we cannot then distinguish what is irreversible damage, what is still active disease, then the overlap with bronchiectasis, colonization, infections, and worsening of the pulmonary situation, to me would mean we need to have efficient first-line treatments. And in this small series that we treated and published years ago, we were able to have BOS reversible. And that not that if the FEV1 was 100%, it's the same back, but it's 82%, and that's where patients do not have clinical symptoms. I think every other salvage strategy is far more difficult, also with regard to response assessment, because you have this overlap of irreversible damage, infections, and other things going on.
Excellent summary. Anybody else? Thank you, Hildegard. Anybody else wants to comment?
So I completely in line with Hildegard. We need very regular PFT tests within the first years for an early detection. This is the key, because at least if, and also if you have some patients that have some viral or pulmonary infection, we have to do some additional tests just to detect early the boss, to have the early treatment. On 12 will be great is now is to move really the new drug in the front line, and maybe to combine belumosudil with AXA in the first line in this kind of patient. This is what we really want to try in this patient to improve the outcomes. But yes, we need to do the trial to have the answer regarding the effectiveness, but it seems very promising.
Excellent. Thanks so much. And just to reemphasize, if anything is emerging clearly over recent years, that patients that have an early stage of BOS, especially FEV1 between 60 and 75, have exceedingly high rate of responses to drugs like belumosudil, ruxolitinib, even the inhaled steroids with beta agonists have some evidence. So, and I have to say, probably we could do a better job in intervening timely. The problem is, of course, these patients hardly have any symptoms at that point. So early diagnosis, completely agree with everybody said. How to rationally choose drug combinations. So we kind of addressed this already, right? How to rationally choose, you can combine lower doses not to have overlapping toxicities, but in terms of increasing efficacy, I'm not aware of any, and probably we need some animal models experiments to figure this out, how to combine them. But I know, it could be different classes, different mechanisms. I don't know if anything else needs to be said on this. If not, we can move to the next. Why do some patients get infections and others do not? Well, I really invite somebody to have some ideas on this. We know that infections are by far the main cause of death in patients with chronic GvHD, even in patient survivors after allotransplant without chronic GvHD. Any insight on why infections are in some patients' problems, others are not?
I mean, what I could mention, and it's not only our publication, but also I think Shiraz Associé and others have published that patients who have a low memory B cell number are the ones who have the higher susceptibility for infections and infectious death. And that means this B cell dysfunction, or we need to have this homeostasis in the different subsets of B cells has a major impact. When we did different organ manifestations, the patients with BOS had the most significantly distorted B cell subpopulations with the lowest memory B cells. In scleroderma, the immune system was hardly involved at all. And to me, this is one of the explanations. And then you also have patients who have functional asplenia. Then, of course, you have this risk for these encapsulated bacterial infections.
Greinix. So we have 3 more minutes. We'll just go read the questions through. So how to diagnose and treat atypical? We know that's a whole new area expanding, and we have new definitions from the NIH task force. What really is needed now, it's more real data and trying to figure out how to treat better these patients, particularly those with lung, kidney, and serositis. They seem to have impaired survival. Why did biological studies not inform these answers? Well, that's I would say, $1 million question. We have so much knowledge, but we are not doing a great job in converting this into clinic. So it could be bottleneck of clinical trials, how much and how fast we can conduct, how to screen for the best and most promising combinations of drugs fast enough. And then why do we not have biomarkers for clinical use? So it's again, right, we know that we have some substantial progress in acute GvHD, lots of many candidates, mostly soluble markers, some cellular like CD19 positive, CD21 negative, but it's really they're mostly diagnostic promise, really no predictive or response measures. So here could be complex, right? Chronic GvHD is a long trajectory, so many confounding factors, so different drugs. It's a challenging area. So I'll stop here. We have 2 more minutes. I would like on any of these questions, the panelists to comment, or anything that's here standing out that you would like to comment on, or any, anything else that's on your mind.
Excellent. Thank you very much, Steve. I think these are really great questions, and we can spend hours and hours actually discussing this, but it's always good to start the discussion, although we may not be able to solve all of these problems immediately.